The application of transcranial direct current stimulation in the treatment of major depressive disorder. tDCS is a non-invasive brain stimulation method used to modulate cortical activity. It produces facilitatory effects and inhibitory effects on a wide range of behaviors. The aim of tDCS is to induce therapeutic neuroplasticity. It works by inducing physiological effects in both the targeted cortical areas and connected networks. These effects can be immediate and outlast the period of stimulation. Action potentials result when depolarization of the resting membrane has reached a potential threshold. This potential is characterized by afferent activity through the electrical synapses, as well as neurotransmitters, which activate particular ion channels and receptors. During tDCS stimulation, the stable electrical current flows between the electrodes and passes through the brain in a circuit. The positive venonal current is used to excite neural activity in the brain region underneath the electrode. The negative cathodal current is used to reduce or inhibit neural activity. Although tDCS does not directly cause action potentials, it increases the possibility. The anodal stimulation causes depolarization at the neuronal membrane, which increases the likelihood of action potentials. Cathodal stimulation hyperpolarizes the neuronal membrane, which reduces the likelihood of action potentials. The current is always flowing in and out of a singular neuron, which means any given neuron is concurrently depolarized and hyperpolarized. The success and directionality of the effects of tDCS depends on where the neurons are relative to the electrical field. It's suggested that due to the sensitivity of the neuronal soma and axon hillock, the direction of polarization to these structures determines the directionality of tDCS effects. tDCS has multiple benefits, including cost effectiveness, easily portable device, and well tolerated among its participants. Physiological effects are known to outlast the period of stimulation and can prove beneficial in the treatment of brain injuries and psychiatric conditions. I've included statistics and characteristics relating to major depressive disorder if you'd like to have a look. Although there's no one definitive physiological cause of MDD, there are some promising theories. The monoamine deficiency theory is the most widely accepted hypothesis. This theory proposes that the root physiological mechanisms for depression are caused by depletion in the neurotransmitters serotonin, norepinephrine, and dopamine in the central nervous system. Nearly every compound that inhibits monoamine reuptake produces an increase in concentration in monoamines in the synaptic cleft, resulting in antidepressant effect. The inhibition of monoamine oxide also has antidepressant effects. There's also been links between the dysfunction with HPA axis and MDD. The HPA axis process produces cortisol, which is a key player in responding to stressful environments in an adaptable way. Variation in cortical stress reactivity can increase the chance of the individual experiencing negative effects related to stress. Excessive, prolonged, or insufficient activation of the HPA axis may result in brain changes that can ultimately result in the development of psychological disorders such as MDD. Glutamate is responsible for the growth and survival of brain cells. In times of stress, there's a moderate increase of synaptic glutamate transmission, which increases levels of neurotrophic factor, which stimulates neuroplasticity. Usually, these levels will return to normal, but in times of chronic stress, glutamate levels may result in activation of N-methyl-D-aspartic acid type glutamate receptors outside the synapse. These receptors are located in neurons and glial cells. When there's hyperactivation of these receptors, there's an increase of intracellular calcium, which results in a decrease of neurotrophic factor. This causes toxic buildup, resulting in atrophy and cell death. Disruptions in this glutamate system may lead to hypoactivity in cortical regions of the brain, and this is linked to major depressive disorder. There's direct evidence that illustrates that a normally reduced function of the central serotonergic system produces depressive-like symptoms. In this research, tryptophan depletion was found to reduce central serotonin synthesis, resulting in the development of depressive-like symptoms in participants at risk of MDD. Patients with MDD also show dysfunction in the blood-brain barrier in the form of neuroinflammation and oxidative stress. tDCS offers a viable alternative to individuals with MDD who may have exhausted other treatments. A 2016 meta-analysis of tDCS and MDD showed that 34% of patients treated with tDCS showed a 50% reduction in symptoms. Studies found that there's evidence that unilateral dorsolateral prefrontal cortex stimulation can improve symptoms associated with MDD. In these studies, the anodal tDCS was applied to the left dorsolateral prefrontal cortex, and cathodal tDCS was applied to the contralateral intra- or extracephalic region. Two alternative studies have utilized the fronto-occipital and temporal regions as an alternative to the dorsolateral prefrontal cortex. Both studies showed improvement in MDD symptoms. Although the exact mechanisms for tDCS and its assistant in MDD are not absolutely certain, there are some theories. One of these includes spontaneous neuron firing. tDCS causes long-lasting changes in neuronal firing. Action potentials do not occur directly during tDCS, but the subthreshold direct current can alter discharge rates. Non-synaptic mechanisms. tDCS may cause a change in the resting membrane potential of pre- and postsynaptic neurons. The nodal stimulation shifts neuronal resting membrane potential towards depolarization, while cathodal stimulation shifts resting membrane potential towards hyperpolarization. Synaptic mechanisms contribute to the effects of tDCS by altering the strength of synaptic transmission. Animal studies have shown evidence that a nodal stimulation can cause accumulation of calcium at the cortical tissue, which regulates synaptic strength. Protein synthesis occurs during tDCS, and NMDA receptors modulate the after effects. Directions for future research include randomized control trials, larger studies over longer periods of time with more representative samples, investigation into tDCS versus other neuromodulation techniques, identification of optimal stimulation parameters, assessment of tDCS efficacy beyond the acute depressive episode, and investigation into biological markers and home use tDCS. Thank you, and please pause to see my references.